This podcast is for informational and educational purposes only. It is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Patients in need of medical advice should consult their personal health care provider. From UPMC Children's Hospital of Pittsburgh, welcome to That's Pediatrics. I'm Steph Dewar, one of your hosts. I am Vice Chair of Clinical Affairs, Co-Director of the Pediatric Residency Program, and a member of the Pediatric Hospital Medicine Division. Welcome.
And I'm John Williams, Chief of the Division of Pediatric Infectious Diseases and Director of the Institute for Infection, Inflammation, and Immunity in Children, or I4Kids. And I am delighted to welcome today our guest, Dr. Megan Freeman, MD, PhD. Dr. Freeman is a PIDS St. Jude Supported Fellow in Pediatric Infectious Diseases, and she earned her PhD under Mark Dennison at Vanderbilt University, actually working on coronaviruses and specifically on SARS. So we have a legitimate coronavirus expert right here in our midst, and she is experienced both in clinical care of patients and basic virology research. And she's been very involved with our institutional response to this pandemic. So Dr. Freeman, welcome.
Thank you very much for having me.
So, Dr. Freeman, I've known you for several years, and I haven't known the background of your science. So please do tell us about your involvement with coronavirus in the past and how helpful that's been in our current experiences.
Of course. So when I was at Vanderbilt, whenever you're selecting a lab, you do a couple of rotations through different labs, have different experiences. My undergraduate research had been in virology, and Mark Dennison's lab was actually the only virology lab that I rotated through, and him being just a very excellent human to work with, a really great lab environment and really compelling science led me to join his lab studying coronaviruses. And I worked on a project that really studied the cell biology of how coronaviruses interact with cells, in particular during infection. Did a lot of microscopy, learned a lot about coronaviruses in general. And interestingly, when I was in the lab, MERS emerged. It was in 2012. And we were very involved with tracking that outbreak, trying to understand more about it, and actually did some of the first microscopy of antibodies directed against MERS in cells.
So I know very little about coronavirus. Actually, mostly what I know about coronavirus is what I've read about probably in the last week or two. And the one thing that I learned, which I was fascinated by, was the sort of 3D structure of what allows that virus to attack cells primarily in your lungs. And I'm just wondering, is that characteristic of this COVID-19 or is that coronaviruses in general?
So I think what you're referring to, Dr. Dewar, is coronaviruses actually get their name because when you look at them under electron microscopy, so essentially at the highest level of microscopy we can do, you can see that they're sort of spherical in shape and they have these little protrusions all around the sphere that makes it look like a corona or a sun. So that's how they got their name. And those proteins are called spike because they're spiky and they stick out of the membrane. And those are the proteins that interact with receptors on your cells for entry into cells. So viruses are unique among other sorts of pathogens in that they have to use a cell for their replication. So if the virus cannot get into a cell, it is not able to replicate. So one of the big tenets of virology is understanding a cellular receptor. So it's sort of like a lock and key mechanism. So if you think about the spike protein being the lock, it has to find a cell that has the right receptor or the key. And for COVID-19, which is the disease, or SARS coronavirus 2, which is the virus, that receptor is the molecule ACE2, which is expressed on a bunch of different cells in the human body, but including some cells in the lungs. And that is where we see most of the disease.
Can I ask, is this different from other coronaviruses? And maybe you could at the same time tell us a little about the other coronaviruses that have been around for a long time, but people don't think about a lot.
Sure. So there are now 7 different coronaviruses that infect humans, and they fall into 2 distinct groups. So 4 of them are coronaviruses that, just like you mentioned, have been around for decades, and they circulate every winter and cause something like the common cold. So that's kind of one group of them. They utilize a variety of different receptors, but a lot of them are in the upper airway. And then there's this bucket of coronaviruses that are the novel or newly emergent coronaviruses, and those include SARS-1 that emerged in 2002. That actually uses the same receptor as SARS-2, ACE2 is the name. And then you have MERS, or Middle East Respiratory Syndrome virus, that emerged in 2012. That actually uses a different receptor, but is still in more of this family that tends to cause more severe disease and lower airway disease. And a lot of the tropism, so what cells the virus is able to infect, depends on the structure of the virus and the receptor that it uses.
So do you think that has an effect on this virus, SARS-CoV-2, the cause of COVID, seems to be different in adults and kids? And could you talk about, how this might play into that, if at all, and then maybe a little bit about what we know about the virus, especially in kids, since we're all pediatricians?
Absolutely. So there are a couple of different theories about why kind of manifestations in adults and children might be different. So one theory is that kids don't get infected with SARS coronavirus 2 as often as adults, which, based on some of the newer data, I don't actually think is true. I think probably what is more likely happening is that kids are having milder disease. So a lot of the kids so far that have been published were even tested because mom had COVID or dad did, and it was a family cluster. It wasn't even necessarily that the kid was all that sick. They were just really digging into the epidemiological link between the family members. So I think there's probably a large bucket of children that had very mild disease that we haven't actually caught with our screening. And as testing has been limited, which has been quite a problem in America, that is another one of the limitations of having limited testing, is really understanding the number of people who have been infected with this virus. Another theory that I've heard, which I think is probably the most likely one, is that ACE2, the receptor expression, is different in adults and children. And this has not been fully characterized, but if you don't have as many locks that are able to be opened, then you're not going to have disease that's as severe. And maybe that's because the cells deeper in your lungs don't express it. We just don't have all of the information about the expression differences in adults and children, but I think that really could explain it. I've also heard some thoughts about how immune systems are different in adults and kids. And when we're infected with a virus, part of the disease that we feel or that we see as providers is the virus itself replicating in cells, and a large part of the disease or the syndrome is the person's own immune system responding to the threat. So as immune systems are different in adults and children, that could be responsible for part of the difference as well.
Thank you. I have learned a tremendous amount in the last however many minutes we've been talking. I wanted to change gears a little bit and have you share with us a little bit about what our current experience and your current experience is like in the current outbreak, and what you've seen, experienced, maybe thoughts about processes that we are talking about improving and changing.
Absolutely. So a lot of what I've been involved with at the Children's Hospital of Pittsburgh is working on our processes of who to screen, how to screen, and who we should test. Because testing has been such a limited resource, and I expect that this is going to improve in the coming days and weeks as we start to get more bandwidth and add additional platforms online in our lab, we'll be able to have more bandwidth for testing. But I've been very involved in how we screen patients. So this has been a moving target because initially, in January, our screening was not really existent from a systems standpoint, but you could imagine, I just visited my grandma in Wuhan, China. That would be a person that you would be interested in screening for this virus. And as the pandemic has progressed, we now have more countries that we have to think about. We have areas in the United States that have local transmission. And I think everyone is expecting that in the coming weeks, we might have more local sustained transmission that we don't currently have in Pittsburgh right now. And actually, John has a lot of the information about kind of some public health screening of viral swabs in his lab that has demonstrated that we have been able to find a couple of positives, but none yet in kids. And that's out of hundreds of samples over the last several weeks.
Can I ask a question about, you mentioned that too. So, the testing, I mean, we have politicians who are not scientists saying, oh, everybody can get a test, everybody should get a test, everybody go get tested. And yet, public health scientists and healthcare professionals and medical people are not saying that. Why not? Why shouldn't everybody get tested?
I think this is a multiple part problem. So thing number one is that testing is not going to change the type of treatment that you receive. And the reason for this is we don't have any licensed antivirals, unlike flu, where we do have Tamiflu or oseltamivir that we can give patients in the first 48 hours of their illness to lessen their symptoms or prevent spread to others. We don't have that for this virus just now. So the advice is, if it's a mild case, stay at home. And even kind of more staying at home than our current social distancing, really, truly try to expose no one to the symptoms that you're having. And most people are going to recover with normal sorts of cough and cold medicines, having lots of fluids at home, and kind of laying low for a while. So I think that's kind of bucket number one. The limitations that we're having is, there are only so many swabs to swab noses. There is only so much media that the virus can live in once the nose is swabbed in order to be able to transport it to the lab. We're having some supply chain issues as a country with the number of swabs needed for this sort of surveillance just hasn't been ramped up to these sorts of numbers in the recent past.
It's really an incredible thing to think that although I appreciate you're highlighting the point that for the majority of people, especially kids, they really don't need to be tested. So we don't need 330 million swabs. But I have to say, nobody was thinking a month ago, hey, we should have 330 million swabs and the tubes of media sitting in a warehouse. So it is kind of striking to me that that's a limitation on our testing, as we just don't have enough.
So as someone who's very much outside this virology process and understanding the demands for the virology, it's interesting to me and somewhat frustrating that these types of viruses have been among us for years, but yet this virus needs a special testing media or test that requires this additional production in order to understand where we are with the spread with this particular one. So I find that curious and frustrating at the same time.
A lot of the tools that we're using, like the viral transport media, is normal media that we use for the RVP in the hospital or other sorts of molecular tests. So it's not that it's a special or new media, it's just that it's a limited resource. And we do use it for this specific new molecular test. So the only thing that's different about the SARS coronavirus 2 test is the primers that are used in the lab and the specific kind of molecular testing mechanism on the lab side. But the collection kits are very similar to what we use for other viruses.
So is that lab part of the process, is that also a limitation, or is that... So it's okay, it's both.
Yes, that's somewhat limited as well, although it has been improving as the weeks have gone on. And as companies are starting to get involved in this as well, they're moving it to some of the more rapid turnaround platforms that we actually already use at the hospital. So as those kits come online, we'll have more bandwidth as well.
So as someone who's, once again, not on the inside of the virology process, it seems to me that there may be some concern nationwide that the numbers of this infection are increasing, but also at the same time, I think more importantly, the numbers of tests being done are increasing, which is what's giving us the information. So I think it's a false sense of reality that in fact we're in the midst of this huge spread, when in reality this has been spreading, I would imagine, for a period of time before we were able to test.
I think that's exactly right. And I feel like one of the best illustrations of that in the United States is actually Washington State. So Washington State saw our very first SARS coronavirus 2 patient in mid-January, and this was a returning traveler from Wuhan. He had seen some of the public health information that he needed to report and be seen if he was sick, and he did that. He was treated, and they kept him, under all the appropriate precautions and kept him into the hospital until he was feeling better. But then we learned 6 weeks later that some of the children actually that had been enrolled in a flu study tested positive for SARS coronavirus 2. And then when they did the sequencing of that virus, and this is where some of this basic virology can really help us with these epidemiologic links, they learned that the virus from the person 6 weeks later had very minor genetic differences from the original virus, which suggested that there had been ongoing community transmission for 6 weeks without it being detected.
Yeah, and I just want to a little shout out to two of the people who really helped, break that open and have saved countless lives. Jan England, a PEDS ID doc at Seattle Children's, and Helen Shu, an adult ID doc at the University of Washington, who were doing this flu study that Megan mentioned, and started doing the coronavirus testing in that study, and discovered that, as you noted, Megan, oh my God, it's like out circulating in the community. So they're heroes.
So now I'm going to turn the table and actually interview you, because Megan mentioned that your lab is also involved in some testing, and you have some data about that. Do you want to share a little information about that for us?
I just want to note that we're doing social distancing here in the studio, but apparently I didn't move far enough away from Steph Dewar to avoid her questions. Well, yeah, we took a page from Jan England and Helen Shu, who had this ongoing surveillance study to look for flu and other respiratory viruses. And we have networks like that here. Our colleague Rick Zimmerman in the Department of Family Medicine has a couple of studies of hospitalized and outpatient adults with acute respiratory illness. And my partner Marion Michaels and I, and our colleagues Judy Martin and Bob Hickey, run a CDC-funded study here to look at kids in the emergency department or the inpatient with acute respiratory illness. So we had these surveillance networks. The other approach that we took was, and there's both federal law and CDC and public health support for this approach, in the setting of an urgent public health need, if you have samples in the lab, in a clinical lab, that are just going to be thrown away. This could be leftover blood, or in our case, leftover nasal swabs. As long as those are completely de-identified, labels stripped off, so we have no idea who that human was, then those can be tested, and you don't have to go back and consent those people because they're not part of a study. It's not research. It's just public health surveillance saying, is it here? Is it not here? Is it here a little? Is it here a lot? So we're really lucky at UPMC Children's Hospital of Pittsburgh and the University of Pittsburgh and UPMC to be part of these networks and to have this resource. So with help from Paul Dupre and the Center for Vaccine Research, we developed the coronavirus PCR testing that Megan mentioned here. And as she said, we've done nearly 400 samples from children, either these de-identified samples or these research samples. We haven't had a one positive yet in a child, which is great. In adults, as people can look at, on the Allegheny County website, we're up to something, I think, in the 80s or something like that. Somewhere between an 80 to 100. In our research surveillance, we've had, I think, 7 positive adults. These are adults from the community. We don't know all of their risk factors in terms of travel for the reasons I mentioned. And of course, as UPMC has said, in the hospitals, there are patients that have been diagnosed with COVID by the clinical testing, although most of those are outpatients. So I think all this is really great news because it tells us, number one, the virus is here. we'd rather have it not here, but we're not surprised, the way these things spread. Think about flu and RSV every year. The viruses spread. The reason it's good news is that we are at a perfect point to avoid what has happened in Seattle and New York City and many other places. We're experiencing this social distancing and quote unquote lockdown, which, all of us feel it. It has a big impact on daily life. And many of our fellow citizens are seriously impacted. People who work hourly and don't have, paid leave time, and people who don't have anything to do with the kids during the day. And all these things, so there's real pain of these social distancing and lockdown measures. However, we are at a perfect point that we can prevent what has happened in these other cities and other countries like Italy to happen here. We don't want to see Pittsburgh become like that, where we have people dying because they can't get on a ventilator because there aren't enough ventilators. And if you look at countries around the world, countries that have done exactly what we're doing now, or even more rigorously, but this painful stuff, Singapore and Hong Kong and even China, they've dramatically slowed the spread of the virus. And countries that were slower to do that, like Italy, by the time they realized they needed to shut down and they made it forced, the whole, herd of horses was out of the barn. So I think it's great that we're not seeing huge numbers. It absolutely tells us that this is the time to keep, to keep the pedal to the metal instead of feeling like, oh, we don't have that many, we can let up. No, this is exactly the time we want to maintain this. Look, when the Steelers are playing the Bengals in a season-ending game, okay, divisional game, okay, they're down by 20. You don't let up. You keep your foot on their neck. You blitz every time. So that's where we are. The numbers look good locally, but we've got to keep up that pressure.
So, John, thank you so much for translating that for a yokel local that can understand exactly that metaphor. That's so very helpful for a Yinzer.
If you put it in
get the
Steeler
Bengal
terms.
Steeler, yeah, it's beautiful. So I appreciate that information about your lab, John. I kind of want to get back to talking with our guest again and ask you if you couldn't share with us a little bit about your path. How did you end up in Pittsburgh in the midst of this coronavirus outbreak? What was your path to medicine, virology, and Pittsburgh?
Sure. So I grew up in Lexington, Kentucky, and I stayed there for college, went to the University of Kentucky. And the summer after my freshman year, thought I was going to get a restaurant job, a good college job, right? But then I got cast in a community theater musical, Fiddler on the Roof, and I needed to be able to go to nighttime rehearsals. So I was a biotechnology major, and one of our requirements was that you do a laboratory-based project for at least a semester. So I thought, what better time? Let's start that now. Interviewed at several labs and found Becky Dutch, who is a virologist, biochemist, studies Hendra virus and Nipah virus. And she actually was the only one that was going to give me my own project and not make me wash dishes. So that's why I picked her. And we had a really great experience working together. And she was very instrumental in kind of my love of bench science. I worked with the person that taught me to pipette, whose name is Mark Worth, was an MD PhD student, went on to be a med-peds allergist and pulmonologist. And he pretty much every day for 3 years thought that he should tell me about how I should be an MD PhD, and he was very influential in that way. So then I moved to Vanderbilt for the combined MD PhD program. We talked about my work in Mark Dennison's lab. And then when it was time to look at residencies, I am hoping in the future to have a basic science and clinical medicine career. So I'll be one of those people who is probably an 80% laboratorian and 20% clinical medicine. Had always liked infectious disease. That went along with my virology interest as well. So I picked Pittsburgh, both because I really liked the people when I came and visited here. Somebody that is another host of this show, Carolyn Coyne, works here. And I actually work in her lab now. And I had seen her give several talks when I was in graduate school and thought, man, I would really like to work with her. So she was pretty instrumental in that decision as well. And we have a great physician scientist residency track here that was very suited to my kind of personal needs. So Andy Nowak is and Jackie Ho are the kind of directors of that program, and we're growing every year. I'm in the second class, and this is a group of people who are interested in being physician scientists, work in labs, and it's been a really nice cohort for me to be able to train with.
Well, I have to say, we've heard a lot of stories, and that may be the most creative one about wanting to be in theater and ending up as a virologist in the midst of a coronavirus outbreak. I mean, that makes perfect sense to me.
But we won't make you sing a line from Fiddler on the Roof.
Not today.
Well, now that we're giving shout outs, I do want to give a shout out to the personnel here at UPMC Children's Hospital of Pittsburgh. I was fortunate enough to work with them this past weekend, and I would say that the nursing staff, the residents, fellows, physicians, attending staff, and also the folks who are coming in to the cafeteria and cleaning the rooms and helping with parking and security and such. I mean, it's really been quite remarkable to be here. We're very fortunate that we actually don't have to live in lockdown because we do need to continue to come to work, but I have to just say it's been really wonderful to interface with all these professionals.
Well, Megan Freeman, thank you so much for coming to join us today. It's just been a delight having you. And a word for our listeners to get more information about the coronavirus. The UPMC Children's Hospital of Pittsburgh and the UPMC websites both have lots of information. And your federal and local public health, whether it's the CDC or your state health department, they all have dedicated COVID pages with lots of information for healthcare professionals as well as lay people.
And I will take this opportunity to remind everyone again, if you haven't gotten your annual flu shot, you still can. And I would recommend that to you this year and every year thereafter for you and every member of your family. Dr. Freeman, thank you so much for joining us. This has been very informative for me. You can find other episodes of That's Pediatrics on iTunes, Google Play Music, and YouTube. Be sure to subscribe and keep up with new content. Leave a review and tell us what other topics you'd like our experts to cover. Thanks for listening.